So we'll go ahead and get started. I'm Tim Chafin, and this is Laurie Colley. We are going to share with you this afternoon our observations while we were conducting the performance improvement workshops around best practices. So what we want to do today is frame the conversation around best practices around the IOCP value stream map. And we're going to share those amongst the 23 sites that are enrolled. And then there's a couple of considerations that we want to share with you before we start giving you the details. The first is, it's a no-brainer, right? A single best practice does not stand alone as an indicator of any kind of success. So as you are looking and listening to the best practices we're going to share with you, it may be difficult to just pick up that one idea and then run with it and implement it in your organization. Nor does it mean that one indicator is the total success. We did see across all of the sites that it seemed to be a much better success with the IOCP program when you had embedded care managers. It doesn't say for those sites that don't have embedded care managers, they're not successful. It's just an observation. And then there's a key organizational framework that is very important for the success of IOCP. And that's vision, structure, and people. And the vision is, not only do the people in this room believe that IOCP and care management and population health is important, but it's part of senior leadership's vision. And so therefore, they're going to support the initiatives that you are putting in place. The structure is certainly what you have done and what you continue to iterate as your programs grow. You have the right structure. And then, of course, probably most importantly is the people. You and all the people that you've hired. Karen, you were mentioning earlier about you got to have the right people, and whatever that means for your organization, and that's critical. So those are just some considerations we wanted to share. So this document, all of you have seen at some version, and this is the IOCP clinical value stream map that we shared prior to the workshops. Starting on the top left-hand side is Foundation for Success, Patient Identification Referral, and then moving along to the right are each of those big buckets that you go through as you are implementing and monitoring and improving your IOCP program. What we discovered as we were pulling all of our data together and our observations, that it's really those four areas that have blue shaded areas around them that are the keys to the IOCP success in terms of best practices. The Foundation for Success, which I'm going to go over, and then I'm going to turn it over to Laurie, and she's going to go through patient identification, referral, supervisit assessments, and guardrails. You might be interested in knowing that the second piece, the patient identification referral, universally, through every single site, was the most complicated, convoluted, and changing piece of this value stream. And it just amazed me the amount of work and resources and time that each of you are having to put into this particular identification stage. So what Laurie's going to identify, I think, will resonate with you a lot. So from the Foundation for Success, there's a couple of key factors. The first is tied to the vision that I talked about, and that is that complex care management is included as a strategic priority for your organization. For those that don't have that, or other organizations, it's not going to be resourced, it's not going to get the attention that it needs to grow to the magnitude it needs to. And then finally, the other key factor is alignment of the IOCP with existing quality initiatives so that they're dovetailed together around the care coordination of high-risk patients. Again, you may say, well, that seems like a no-brainer, but that may not be true in every single organization. So best practices are there. Starting on the left, senior leadership support is critical to the success. In other words, they have the visibility, they have the engagement, and they give the support. I know in some of the sites we had leaders stop by and say hello to show their visibility and support. I've heard many of you talk about the support you get from your senior leadership, whether it's in that single organization or in a larger organization. That's critical to success. The second one that we identified that is really critical is a dedicated physician champion and a project champion. The physician champion is critical, and I'm going to pick up on what, Greg, what you stated earlier today with Dr. Hassan joining the group as a dedicated physician to help with the IOCP program. That's a great example when you have that absence, that gap, and you fill it in terms of your program dimensions, you're going to get much greater success. Not only in terms of the engagement with the physicians, but in terms of the overall accountability and the responsibility, the daily management, the interactions that the physicians have with you and your teams, as well as the program outcomes. Third is, we saw best practice when it was associated, the IOCP program was associated with an existing care management program. That's not exclusive, because we've heard others in the room say, we really didn't have a care management program when we started, and they've done a really great job. Instead, what this really does is it reduces the startup time. It allows you to jumpstart the entire process. And then it provides insights into the intersection of IOCP into your existing program. So we found that as a best practice. Nursing leadership and monitoring and mentoring. Not every site has the ability to have a nurse, but when we saw that nursing accountability present at that site, we saw much better results. And what that does is it ensures guardrail fidelity. It gives clinical intervention that's appropriate at that point in time as it's needed. Multidisciplinary team. We heard a lot today as we were going through the introductions about how you started out with a program that was this big, and it's grown, and you've bolted on a pharmacist, or you've added social workers, or you've added healthcare navigators that you didn't have before. That multidisciplinary team really helped support the health of the entire program and speed success. And then the last one is embedded care managers that we mentioned before. And that, of course, fosters the PCP engagement. It ensures timely referrals and engagement with the patient, and it facilitates enrollment. So I'm going to turn it over to you, Laurie.
Okay, so when we first started with all of the groups, there was this implementation phase where the PBGH staff, along with our clinical advisory committee board member, came out, and we actually did, on-site meetings with all of you and talked about the IOCP program and, how are we going to make this all happen and all the training that was going to be involved. So you kind of think back on how we all started, and there was a lot of, scary moments of knowing how are we going to get this going. What staff am I going to use? But you know what? You did it. Some of you jumped into the shallow end, and some of you jumped into the deep end. But look where we are today. So I think the process improvement, it really provided a great opportunity that I saw that all of you were able to bring the workforce together at the table and with our big long piece of butcher paper and really document and really look at the steps that all of your staff were conducting. And I think that was really critical. And I had many of you say, Laurie, I don't know if you and Tim hadn't come out, if we really would have been able to pull everybody together and really dedicated a day and the time to do this. So it was really beneficial because there was a lot of aha moments. There was some moments. And then there were some ta-da moments, right? But, we really came away with recognizing, there were some areas that needed some improvement. There was some new staff that you all had in place. And it was also, it provided an opportunity for the new staff that did come on board since we did implementation, or maybe they hadn't received the 3-day Care Coordinator Academy training, that it was an opportunity for them to really see the whole landscape, the straw man that Tim put up the beginning, that really showed what are all the buckets and what are all the steps that are involved in all these steps of the implementation of, the care model. So with patient identification referral, we talked in the very beginning about the whole campaign with your physicians, your leadership, with your internal and external communication and marketing plans, because there needs to be a campaign. And it has to be ongoing. You can't just go one time and meet with the physician groups or the staff or the office manager and expect for it's just going to be flying on its own. It doesn't work that way. You have to constantly be meeting with the people, bringing back information. Maybe you need to rework your campaign. Maybe there was something that was missing that really wasn't grabbing their attention. And plus, as you gain knowledge on your program, you have better words that work, because now what do you have? You have stories to share with the physicians or the office manager about how this IOCP program really impacted those patients. So developing your marketing and communication plan, and it's not just the physicians and the office staff. You have to think about the hospital and the skilled nursing facility, the community resources. Think of all the different doors that the patient's going to be going in and out of, and establish those relationships and create the campaigning and the marketing and communication plan with them as well. Using your IT and data resource people to pull data for you. Scott's done an amazing job, the project managers at your company, same with Trent. Having the project managers are a key part to be able to pull data that is informative to the care team, so they can really do quick analysis on what's working and what's not. And then also being able to pull from other patient identification, for example, registries that you may have internally, and look at and cruise those lists, the lists from the ER and the hospital. Get into a habit of having that in your process, and it's part of what you do on a daily or weekly basis as far as looking for potential patients. And engaging those folks, at the hospital and at the skilled nursing facility, and building those relationships with them so they're comfortable with you coming in. Or maybe they're going to pick up the phone and call you and say, I've got a patient over here that really could use care coordination. The centralized referral line works when there is an 800 number or a central point that comes into a call center, and then there's a person that is focused and dedicated on that initial intake of the referral and can triage that and do all the work and understand what program does that patient go into. Because that alleviates a lot of the thinking and work of the physician. Of if you have multiple programs going on at your organization, that physician's like, I don't know what program they go into. So make that 1-800 make the decision. Make it easy. Put that 800 number on the back of their name tag. Make it part of the employee onboarding and orientation so everybody knows about care coordination in your organization. The super visit. This is where the magic happens. This is where that relationship starts to build between the care coordinator and the patient, the physician, the team, that really allows the opportunity for that patient to tell their story. For a lot of patients, it's the first time they've ever been asked to tell their story. Put the stethoscope down and have that conversation with the patient. That's why in our 3-day Care Coordinator Academy, we had dedicated 1 day to motivational interviewing. It takes a certain skill set to have that kind of conversation with patients, but there's a lot of resources out there on motivational interviewing. It's a key element as far as training your staff on those techniques, on being able to talk with the patient, how to listen, be empathetic, understanding, and just allowing that time and not be rushed. That 7-minute or 15-minute visit that they have with a primary care physician, they usually are in there, they listen, and they leave, and the doctor is saying, I want 10 pounds off of you, I want your blood pressure down, and I'll see you in 3 months. How's that working for them? So I know I was over at St. Joseph's, and one of the primary care physicians said to me, he says, Laurie, I can't believe the difference in my patient. They come in the door now, their head is lifted up, they got a smile on their face, they're engaged. I've been trying to do that for 10 years. Once I got a care coordinator, this is what my practice is about now. So you're all seeing that now. We went around the room today in your introductions and you were sharing stories. You feel it in you now because you see it and you have seen the outcomes, not only just personally to that patient level, that patient care, but you have data now to support that. You know, as we see engagement and activation increase, all that other stuff follows. They start taking their medicines. They're out of the ER. They're out of the hospital. They're engaged with their physician and their other providers and specialists. It's a healthier patient. It's a healthier practice. The community resources, it's a vital, as far as having met with the community resources before you even go live is very important. Karen shared with me at Scottsdale, she created a monthly in-service, Karen, that you bring in the community resource vendor. So get to know them, ask them to come out and speak with your staff, because there's lots that they can provide. Even the Area Agency on Aging can come out and talk to you about the resources financially for these patients. So there's a lot of resources out there, and sometimes you just don't know who they are and how to get hold of them and what kind of services they have, so they can bring in their materials and leave it with you and make that an ongoing process for your staff. It's for weekly. Oh my gosh. Yeah. So that's a great idea, because we're very busy, and so and just knowing who to call, and when you have that, and especially establish the relationship with those people, when you pick up the phone, they're there for you. The medication review, you mentioned some of you brought on your pharmacist, so that's great. If you don't have a pharmacy, you were very creative, or pharmacists that dedicated the team, you were very innovative in maybe using the residency program and having those residents help you with the medication reviews with patients, because we're seeing a lot of polypharmacy. Shared action plan, this is what the patient wants to work on. Right? It wasn't that physician saying, I want 10 pounds off, your blood pressure down, come back and see me in 3 months. This is what, through your assessments, now that's another good thing about the assessments. The assessments allow you to really measure where and how you need to help that patient. So I've had a lot of the care coordinators ask me, Laurie, how can I use these? Teach me how to use these. But it's really looking at the questions and the answers, and taking it a bit further with a patient and having that talk. It's not necessarily really having to have them fill it out face-to-face with you. We encourage you to go with the flow of the patient of how they wish to fill the survey out. But the fact that you're bringing the survey back and going over it with the patient and having the conversation, and maybe looking at some of the answers and saying, can you tell me a little bit more about this? Allows you to understand and see what makes that patient tick. Because you use that then in your coaching technique, especially with knowing where your patient is in their activation measure, between 1 and 4, 1 being the lowest activated, 4 being the highest, of how can I steer that patient? The baby steps that are going to happen, or they can take bigger steps, because the baby steps are going to lead to bigger steps. And for them to have hope for the first time in their lives, that's sometimes what they needed, is just some hope that it's okay to start with a baby step, and then they complete that baby step, and now they're engaged, right? You've activated them through 1 baby step. Give them 2 more. So that's about the shared action plan, is really utilizing those assessments and then asking the patient, of course, what they want to work on. The guardrails we really created so that there would be a framework for measurement across all the medical groups. So these are what were in place. This is something, too, we found out during our process improvement, that there were some OOs. But that's okay. We put an action plan together and got the focus redirected. And sometimes it was just documentation that needed to occur. So we got the processes in place after our visit. So the super visit takes place within 1 month of enrollment, right? And that is the face-to-face, and that can be in the patient's home, in the primary care physician's office, or maybe you have a care management office that's taking place, as long as it's face-to-face. The only exclusions we have for IOCP is hospice, but we've allowed you to add any additional exclusion criteria that you wish. Vetting the patient list and making sure they're attributed to a primary care physician. We want to make sure that the primary care physician, gives him or her blessing on the patient being enrolled. So that's why we want you to make sure that you are vetting your patient list with the physician. The face-to-face taking place within 30 days of enrollment, and then completing the assessments within 30 days. So especially with the care coordinators that are doing the intake at the hospital, it may be a little bit difficult at the hospital to do all 3 assessments. So, giving the patient the choice to take the assessment home with them, and that you will follow up through a phone call, or perhaps we'll make an appointment to come back in. So giving the patient options of how they want to complete the all 3. Again, the key is bringing the assessment back, so there's then the clinical review of those assessments and looking at the questions and answers. And then maintaining that touch point, that two-way communication with the patient on a monthly basis. All right? And that can be telephonically or in person. The last one is the 24/7 access. So this is making sure that there's a after hours, weekends, and holidays. There's a number for the patient to call so that they're directed to some level of care, or they're provided some type of information, answers to their questions. And then there's a loop around back to the care coordinator within 24 hours or the next working day.
Rob Benroth couldn't be here today, so I'm going to do my best to be, as I say, data man. So don't ask me really tough questions. And I know that means I will get a lot of tough questions. But these are your results based upon your implementation of the IOCP program and working with PBGH and completing the assessments. These are the collective results for all of you. And the first one is the PAM. And I think everybody knows, as Laurie just went through, you have initial PAM at the super visit, and then 6 months post-enrollment, you do another PAM. And then if you've had patients enrolled a year, you do another PAM. So the data that you see here that I'm sharing with you is the initial PAM, and then wherever you are in your organization, if it's the 6 month and you haven't done a year, it's the 6 month data or it's the year data. So that's how that's aggregated here. And you're going to see that there are 3,186 patients that had repeat assessments as of the end of calendar year 2014. Up at the top right, the baseline average was 58%, and the follow-up average was 61.2, and the scores improved 6.2%. And then you're going to see, for a breakdown for each one of the levels, starting with level 1 on the left to the right, blue represents the baseline measurement, and the red or orange represents the follow-up. And what you're going to see is higher activation of the patients moving and shifting from level 1 to level 4, and that's a result of what you and your staff have done with the patients in the IOCP program. So that's a really great story for you to be able to take back to your organization and share with your staff. I know a lot of you have already done this because we presented it on the leadership calls, but we thought it was worth spending this few minutes to share this with everybody. According to Dr. Glasseroff, a 3-point difference is statistically significant, and we moved it up that 3 points. You moved it up those 3 points, so congratulations. And this sample size is 1,309 patients with repeat assessments, and this was for the same time frame, ending calendar year 2014. And as you know, there's 2 scores. There's a mental and a physical health score. On the left-hand side, the mental health score initial is 48.85, and the follow-up is almost 51, and the physical health, 31.21 to 32.43. So there was a 4.6% improvement in the mental health score and 3.9 with physical health. And again, that's the result of what you're doing with the patients in the IOCP program. And to quote our clinical advisory committee, they said that is a profound movement. And the reason being is in a senior population, what you expect year over year is a decrease. And the patients that you're taking care of, they have gone the other direction. So again, this points to the power of the IOCP program and how you're implementing it and owning it and managing it.
I want to add one more thing on that, Tim, is that how profound this is this is addressing the activities of daily living. So the burden of their disease and the activities of daily living, and to have this kind of impact on the mental health and the physical. I mean, my years of care coordination, care management, I never saw any VR12s move in this direction like this. So again, this reinforces the philosophy and the body of the work.
And then the depression score, which is the PHQ, it's the same time frame for the end of 2014. It's for those patients that had a baseline and a follow-up. So this is just the opposite, as you already know, but let me point out to the PAN. So minimum depression is on the far left, severe depression is on the right. The blue represents the initial baseline score, and the orange or the red represents the follow-up. And what you see here is that the baseline was at 5.25, and the average score for follow-up was 3.55. So that means patients moved from severe depression, moderate severe depression, to the left to less depression. And that is significant because 21% of the patients moved from a less severe depression category at follow-up. Again, all three of these scores, which take a lot of your resource time to facilitate, to get the results, to actually put it into the EA tool, this demonstrates the IOCP program and what you're doing is having a positive impact. So congratulations on that. Anything you'd like to add, Laurie?
This needs to go on all your bulletin boards. Okay, so I'm talking about campaigning. This is huge. So, you know, with your staff, celebrate your staff, the good work they're doing, you know, and take this to the medical directors, take this to the CEO and CFO and say, look what this program has done. We are providing better care.